Well, hello everybody, and welcome back again to the most compelling 30 minutes on the internet at 4 p.m. Eastern Time, talking about innovations in the business of healthcare. My name is Chris Seper, and you are back with MedHeads, MedCityNews.com's weekly conversation on innovations within the business of healthcare. And we're excited about this conversation this week because it really does tackle one of the things that we think is probably one of the hottest spaces happening in innovation today, one that has one of the highest potential still to change, and one that still has some big challenges, some big unanswered questions. I'm talking about telemedicine. I think it's telling to me, as someone who's been to the American Telemedicine Association conference over the last several years, the growth and the diversity of the companies that are coming into telehealth. And obviously, if you read Rock Health reports or other areas like that, you see and hear so much about telemedicine. So we're going to talk about it, and not just talk about telehealth in the big picture, but what we want to talk is what I've been calling the nichification of telehealth. Telehealth is now moving simply beyond big video screens or phone reminders or so on, into specific clinical areas where it's beginning to understand how to go deep. And so we have a collection of big thinkers to talk about that this week. From Eureka, California, he is a father, a husband, a brother, a son. He's also a palliative care physician, and for our purposes, he's the founder of Resolution Care. And he also is the easily undisputed man with the best backdrop ever. For any in the history of MedHeads, it is Dr. Michael Fratkin. Dr. Fratkin, welcome.
And he's a Med Citizen.
And he is a Med Citizen and a regular contributor to MedCityNews.com. The man who offered that insight is in beautiful Chicago, Illinois. He is Neil Versel. He covers healthcare technology. Neil, how's life?
I'm a little disoriented today because of this bright thing in the sky. I'm not really sure what it is.
Here comes the sun. Here comes the sun. Anyway, and finally in Philadelphia, who covers early stage digital health, Stephanie Baum. Stephanie.
Hey, how's it going? Just recuperating from the Mobile Health Summit.
That's right, the Mobile Health Summit. That's great, and we'll probably talk a little bit about mobile health, but I want to start with our conversation on telemedicine, and I actually want to start with Stephanie and Neil. And Neil, you go first, and Stephanie second. I want to hear a state of telemedicine. Like I said, this is a place of big opportunity and big challenges. Just characterize where you see telemedicine right now as an industry contributing to healthcare.
Well, I think we want to start with defining what telemedicine is, and I'm just going to read off the American Telemedicine Association's website, which says telemedicine is the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. And it could include two-way video, email, smartphones, wireless tools, and other forms of telecommunication. So that said, the other forms of telecommunication seem to be, from my viewpoint, falling off a little bit, and that's just plain old telephone service.
Mm-hmm.
Although I think some people would also throw text messaging in there, which is a lot more powerful than a lot of people think. You don't have to have live video, you don't have to have a cool app, and you don't have to have a strong interface. Text messaging is basic communication, and it works very well in many instances. Anyway, I think telemedicine's getting more sophisticated, and I think as we're going to hear from Dr. Fratkin, I think, Chris, your word is being nichified, because we're finding so many new applications for telemedicine, and with the basic technologies that have been out there for a while, and with some new technologies too. For example, do you want me to go into an example, or do you want to?
Sure, that'd be great. Yeah, okay. Fire up.
A week ago, I did a piece about a pilot test that the VA is doing at 3 sites, one of which is San Diego, and the story that I got wasn't clear on what the other 2 sites are. Real-time video telehealth services for primary care for the first time, and not just to expand the range of specialists. So moving into primary care, and I know that Dr. Fratkin himself is a primary care.
Mm-hmm. Well, Stephanie, let's turn to you. I mean, when you think about telemedicine, again, I mean, Neil is there with the payers and providers looking at how they apply technology. You're there at the early stage innovators as they're creating some of these new solutions. I mean, what's your point of view on the state of telemedicine?
I mean, I think Neil made a good point earlier about the usefulness of text messaging and just simple things like that. That is part of telemedicine, and sometimes it's the simplest solutions, the most elegant ones. Simplest solutions are the most elegant ones, and so I see plenty of examples out there in telemedicine. But where I'm seeing the most interesting telemedicine companies, the specialty areas, they tend to be divided between this two-way interaction via video, supported by things like text messaging and transmitting data from connected devices, but also sort of, especially in the area of teledermatology, kind of taking pictures and sending them to either a primary care physician or a a dermatologist, and kind of a store and forward technology.
Interesting. Well, now I want to turn to Dr. Fratkin for a second here, and that beautiful background. I think you know what is interesting. You're here, and because you're in that group of people going deeper with telemedicine. So I'd love for you to talk about resolution care to make sure that everybody understands it, and then talk to us. I mean, there are cycles of telemedicine. You know, where are you fitting, and where do you see things going on now?
Yeah. Thanks, Chris. Thanks, folks. It's great to be here. And you should know that's a $70 piece of photo mural slathered onto a wall. So there it is.
Was it reimbursable?
It was reimbursable. It was
Yeah.
built into a grant.
This is a $20 roll shade from Home Depot.
There you go. There you go. It works. No, resolution care was a number of things. It was essentially my Hail Mary for burnout. In a palliative care program. What we're doing is we've created an independent and nimble community-based palliative care program that leverages a couple of things. One is the off-the-shelf video conferencing technology that has matured so that for $42 a month I can use Zoom to do most of everything that I'm doing. In addition, people and connectivity, devices and connectivity are everywhere. And though we're prepared to provide telemedicine gizmos to people and to get them plugged in if we need to, we haven't had to do that because pretty much everybody and their mother, even their mother and their grandmother, have a device that works, at least, or they can get one pretty quickly and they can see the value themselves. The other thing is that we, as a palliative medicine initiative, are kind of right down the middle of the plate in the changes that we're seeing in reimbursement and the economic incentives in healthcare and what we call value-based payment. We can come back to that. But essentially what we are is we're a bunch of palliative care specialists, a nurse, a doctor, a social worker, a chaplain, community health worker, that are moving the locus of care from clinics and hospitals and that sort of thing to people's homes. So we're doing house calls and virtual house calls to add palliative care as an extra layer of support to the care that they're receiving in cardiologist office, oncology offices, or even primary care settings. Palliative care, just in case anybody knows, is simply what happens when people who are no longer able to maintain the illusion that they will live forever are cared for by people who are able to maintain that illusion, like you and you and you and me. It's people caring for people, not as patients or disease states, and it's doing essentially what makes sense from that simple perspective, with the understanding that completing life is not fundamentally a medical experience.
Well, and let me I want to stay with you a little bit because I want to dive deeper. I mean, how much different is a telehealth palliative care experience than there would be a one that we'll just call it traditional? I want to call it face-to-face, right? But how is it different, and where is it better, and where is care changed or challenged or different or degraded?
No, that's a great question. You know, my assumption in starting was that it would be fundamentally less than. And while there are certain things that you give up, there are certain...
Like what?
Well, intimacy, being able to eat their cookies and drink their tea, be able to easily move around their living room and take in the way that they relate to their environment, their dog and their cat and how they relate to their cat. They're looking inside their refrigerator to see how they manage their nutrition, how they store their medicines, either in a huge pile or entirely structured and organized. You can pick up a lot of information very quickly when you walk physically into a house, and it takes a little bit of creativity to get that same experience with a device. But you can. You ask them to give you a tour, and they want to give you a tour. They want you to see them for who they are. So you ask them, and so do you have any pictures on the wall? Who is that person over your head? What's your dog's name? Here's a picture of my dog. Engage in trust building. So there's that, and I can't hug them, and I hug most all my patients except for the ones that are nervous about such things and don't like it. So yeah. I can't do that. But what I can do is what I can do with the viewers of this broadcast and what I can do with my colleagues with whom we're having a conversation. This technology provides a constrained tunnel of attention, which in some ways is superior to what happens when you're sitting in three-dimensional space with people. I did not realize that before I got started. What happened that surprised me is because palliative medicine is a very deep dive into who a person is, how they see themselves, how they understand their illness, and how they want to proceed going forward, as well as symptom control, advanced care planning. It's a sit-down, time-intensive encounter. So I gave about 2 hours for an initial home visit, and then I started to do a few of them remotely. And what I realized is that about 60 or 70 minutes would go by, and we were done. That we had done all of the relational work that had to be done, and all of the sort of checklist of things that are included in most initial consultations in about half the time, without driving, without parking, without them having to get themselves all dollied up to go to the doctors if that's their predilection, without them having to get into their wheelchair, get the wheelchair into the car, all that stuff was gone. And the encounter itself, because of a bit of magic in the technology, is a very focused way of engaging attention.
Well, does that make you as much money as if you saw him in person?
Well, it's a funny thing that you should mention that. At this point, we're giving away most of the care that we're doing because we're invested in the future of healthcare payment and the good efforts of the American Telemedicine Association, as well as CMS and the payers, to get their head around the idea that if you go to people's homes, virtually or otherwise, understand who they are as people and how they understand their circumstance, not only can you improve their quality of life dramatically, improve their ease and engagement, satisfaction with the process of receiving healthcare, but you can save buckets of money. And we're invested that our institutions and policymakers are getting that message, and in the next year or two, we'll have a sustainable revenue model. Right now, it's bake sales, barbecues, and all the rest of it to try and scare up money to support us going forward. So we've estimated we've given away about $50,000 worth of care in the last 9 months or 10 months since we started. But we also estimate that we've saved our patients 10 to 12,000 miles of driving, untold hours, and probably $5,000 or $6,000 in personal costs that they would have otherwise had to incur to get to the hospital. I mean, these patients, you got to realize, these are people with cancer, with serious illness. They end up going to the doctor, the laboratory, the x-ray, the emergency department, episodic care, to primary care physicians, doctors' offices for about 150 visits in the last year of their life.
Well, I want to circle back. I mean, I really want to circle back in a little bit, Neil and Stephanie, to other industries beyond palliative care where we're going deep. But this seems like an apropos moment. There were two things mentioned that I would love more feedback on, and it's about barriers, right? I heard two things that stuck out, and again, Neil and Stephanie riff off this a little bit. it's very easy to do telemedicine because everybody has a phone, yet it seems difficult to get it implemented. One thing I just heard was because of reimbursement. When you think about the challenges for telemedicine, and I saw Stephanie, saw you nodding your head, so let's go to you first. I mean, what is keeping startups, Stephanie, from getting telemedicine solutions to market faster and being then successful when they're in market?
I mean, I think obviously the reimbursement factor is a big issue, and I think that has. I've noticed that it's. I mean, I don't know if it's necessarily keeping people from going to market faster. It's just it affects the direction that they go in and how they work. You have maybe that is one reason why teledermatology became such a big issue, that they would, so that you basically pay like $50 or something like that. You take a picture of your weird growth or something, and companies like Dermatologists on Call will evaluate that and give you a response. I think they claim to do that within 12 hours. So you have that way, but even Highmark has started reimbursing for that. So instead of $55, you pay $45. You're still paying something, but you're getting something as well. So I think a lot of the more interesting telemedicine companies I see out there are pursuing areas where they are going to be filling a pain point, and there is going to be a big but it'll take time. Like one of the most interesting companies I see doing that is Reflection Health, and they are combining telemedicine with physical therapy, recuperating from surgery, specifically hip and knee replacement surgery. And one of the reasons why they focused on that is that they envision that being a bundled payment where you're going to have like about 5 or 6 parties that have to track one patient and make sure that their outcome is okay. And the way that they have a platform that uses Microsoft Connect, and so it's a motion capture platform. Patients kind of go through their physical therapy routine so they understand if they're doing it correctly or not. And when they do it from home, they can transmit this information back to a physician or back to they can transmit it to the relevant care team members, and so they have that information. That's just one of the most interesting things I've seen, and so there's that.
Neil, what about you? I mean, what do you see? I mean, you're on the other side of it, right? What's keeping payers and others away from maybe embracing this as much, or what's keeping telehealth away?
Well, I think some of it is resistance to change. The American College of Physicians put out a statement, I think it was back in September, saying that they would like to, they wrote a position paper actually in the Annals of Internal Medicine, making it pretty much official, where they said we want more telemedicine, but we really want it on our terms. 2 specific caveats that physicians really need to be involved in this. And, that, if you're talking about patient care, yes, but there are some other forms of patient care, which, by the way, aren't as dependent on reimbursement that I've seen growth in telemedicine. One is there was a report a month and a half ago about how more hospitals are using telemedicine to bring chaplains to their satellite facilities.
Oh, that's interesting.
Yeah, there might be chaplains on call at the big urban hospital, that at the community hospital, there only might be chaplain for one religion or one denomination, that sort of thing, and they may not be available around the clock.
Well, Dr. Fratkin, I want to circle back to you, on anything that you heard here, but in specific, I mean, I think there are specific challenges for reimbursement for you, right? I mean, this isn't just, there's, team-based interventions are where you want to live, and is there specific problems, even in trying to change the minds and get reimbursement around telemedicine when it comes to that area?
Well, there's an opportunity that we're taking full advantage of in collaboration and partnership with the Medi-Cal or Medicaid Managed Care Organization Partnership Health Plan. They manage the lives of 500,000 or more northern California Medicaid participants, and we're involved in a pilot that's a collaboration with the California Healthcare Foundation that is testing the value-based payment model, a per member per month capitated rate in palliative care, and we've been allowed, we're the only, obviously the only group using video conferencing technology to extend our reach, but we are paid per member per month to provide services. We've overbuilt our system and are providing a really robust trans or interdisciplinary team in an effort to demonstrate that you get what you pay for. And so we're seeing a number of patients over the next 6 months that we get paid a per member per month amount, and that's enough for us to support a social worker, a chaplain, a nurse, community health worker, and myself. In that kind of a scenario, they don't care how many times I see them. They don't care how much I do to them. They don't care how many billable visits. They just want to make sure that we deliver on the aligned promise that people are going to feel better, experience greater well-being and satisfaction, and at the end of the day, a return on investment that's at least cost neutral for that payer. So rather than being at odds with the payer to try and negotiate the best rates to do more stuff to people on a fee-for-service basis, we're working together to solve problems and to deliver the kind of care that, you know, if I save for one person over 6 months, if I save an emergency room visit or an unnecessary desperation scan, I paid for myself and then some, and provided the kinds of services that are centered around that person that they can't possibly get. For example, we took a 90-year-old man who's been caring for 12 years for his bedbound wife. We had our local ambulance service take them outside, and we made them a dinner for their 73rd wedding anniversary. And we spent a few dollars, and we put our resources into it, and it delivered enormous value for them. That's the first time she'd been outside of her house for 12 years.
Wow.
And they are better, and she is better on behalf of that. And we can write that check because it's what makes sense, right?
Do you think the challenge, I mean, that's the compelling story, is the challenge with telemedicine right now is that there's not enough traditional clinical evidence to support, getting reimbursement or convincing a big hospital system with many portions of telemedicine. I mean, hospitals are using it, but is clinical evidence an issue?
Sure, it's an issue, but it's not an issue for me or the patients I take care of. It's an issue for the people we're engaging in partnership. So that's my challenge as a developing entrepreneur, to make that case for people in a way that's compelling to them. I try to appeal to them not as capitalists or venture people or business folks or hospital systems, but as people who were born, live a life, and will die. I think it makes such sense that the accumulating evidence that palliative care improves outcomes, improves satisfaction, and reduces costs is compelling enough. The evidence is adequate, and that we can do it with telemedicine. Seeing is believing, and we're being given a chance to participate in pilots, and we're just doing it because it bloody well does work.
This has been great conversation. I want to circle back with one more question before we wrap, and that's about other sectors. Dr. Fratkin, I'm going to start with you this time. Obviously we've talked about palliative care, but are there other sectors that you look at that either you're watching to take cues from as you try to advance your area, or are there other sectors that you think are going to be, rich opportunities for telehealth innovation?
Yeah, I'm watching the shifting economics encourage case management structures, or how little can we get away with in terms of serving people from a value-based payment model. There's something called the Medicare Choices that is adding a $300 per month capitated rate for hospices who want to work in a palliative care way in addition to or concurrent with disease-directed care. That will, in that environment, incentivize hospices to do as little as possible. to wrap their head around the needs of people who are maybe dealing with chemotherapy for a year or 2 years, dealing with their mortality, and I don't think it really delivers. So I'm trying to set the bar higher at a more comprehensive offering to people in the last 6 to 18 months of their lives. So that's one trend I'm watching. The other is I just watched the technology that I pulled off the shelf to use get better and better, and I'm hoping that Jonathan Bush and Athena Health, the only CEO who seems willing to say that EHRs suck, is the only one I would trust because of that. I'm looking to see if that sort of a platform can begin to evolve into something that is not like the other organizations that control their marketplace with proprietary firewalls. So I'm looking for an opening. And I'm directing my attention not really so much at the business end of things. I'm just building what works for people and to provide them the experience that they all deserve and have not been getting in our broken healthcare system. And then I'm just hoping that by talking and promoting what I do and being clever in business development that the money will come.
Neil, what about you? What sector do you think is going to take off? Or you think is exciting?
I think there's an option now sort of segueing into, I know what your next question is going to be, which are our stories of the week. I think there's an opportunity in making in expanding coverage. The story that I was going to talk about isn't directly related to telehealth, but it certainly has potential to include a lot of telehealth, and that's a story that I did on a Texas health plan, Driscoll Health Plan in South Texas, with Corpus Christi, which is affiliated with Driscoll Children's Hospital there. Texas, of course, is one of the states that did not expand Medicaid under the Affordable Care Act. However, Texas does have a pediatric program for trying to be more efficient in caring for kids. The pediatric component starts a year from now, and this health plan signed a contract with the state, not knowing what rates they're going to be paid, but sort of taking what they called a leap of faith, that they will be able to be efficient and in coordinating care. They cover an area of this contract that Driscoll has to cover kids covers 24 counties in South Texas, 25,000 square miles, which is bigger than many states. And it's very rural, it's very poor, and obviously the potential of telemedicine is out there to reach all these kids across such a wide area. I think the health plans are now looking into that. This is a health plan that's doing that. And at some point, they're going to see the value in being able to extend care. I think the VA sees the value because the VA is a closed system and essentially is a single payer.
That's right.
So it's good. Yeah.
Some of the other closed systems are seeing that as well, Versel, for example.
Great.
Not closed, but that have the incentives between the payer side and the provider side aligned. And
So
does a lot of that too.
So Stephanie, what about you? I mean, where do you think the next promise is? What's the next telederm?
I mean, I think we should actually be looking at telepsychiatry a little bit in terms of, I think that's one of the most interesting areas, but particularly how it fits into a clinical setting, kind of complementing the primary care team. One of the startups that MedCity News has followed for a few years, One Doc Way, just got acquired last week, and that was a really notable exit for them. But they got that way because they worked within the system. They focused on collaborating with doctors, focused on areas that would be reimbursed by Medicare and Medicaid, and that's usually within sort of a clinical setting, and they were able to provide telepsychiatry, tap their pool of telepsychiatrists to provide care in places in vast areas of the country that don't have the access to those specialists. But I think I'm seeing a lot of interesting startups that are focusing on providing psychiatrists by video hookup as a way of complementing a primary care team.
That's great. Yeah, interesting. Well, I want to thank everybody for being on this. I think if we can peel back the onion on telehealth when it comes to regulation and reimbursement and continue to build the evidence, it's going to be a fascinating few years.
Before you sign off, I encourage
Sure,
people, by the way, Dr. Fratkin was featured on PBS back in, I think, in August. It's a 7-minute segment. We wrote about it. Go look it up, watch for it, or just search Fratkin's name on MedCity News, and you'll find the story that I did that links to that video.
I'm always in favor of people searching on MedCity News. I'll just tell you that right now. So before, as we get off here, as always, we end with the story we thought this week was the most important in the area of innovation, and I'm going to go with the Misfits Wearables acquisition. I think there was a certain amount of me that said stick a fork in it when it came to wearables, as this hip hop growth industry. At the Rock Health Summit, when they talked about wearables, I got the distinct indication that wearables were kind of like gym memberships, right? You bought them and then never used them. But
that's exactly that's what Zeke Emanuel said the week before last at the.
Yeah, but I think I think this is a validation that the fact is there's still really specific high-value applications for wearables. We can't always be so literal with it, so it was really impressive. Stephanie, what about you?
Well, I thought the collaboration between the study between Omada Health and Humana to the 6-month study looking at Medicare Advantage patients that were kind of identified as being at risk for developing diabetes. I think the pre-diabetes patients, they had access to Omada Health's digital health platform, connected scales and that sort of thing. And I think they found from their study that the average patient lost like 8.7% of their body weight. And it was, it's a really neat story, and it's really encouraging because, myself included, I tend to kind of write off seniors as kind of like, well, the tech savviness varies so much, and it's so easy to get frustrated when you're learning something new, especially as you get older, and they would never be able to kind of retain attention for that long. And the fact that they were able to get these kind of results, that speaks well of the future of applying digital health to seniors, and it'll be interesting to see what more progress they make, especially as they go after the Medicaid population with their platform.
Dr. Fratkin, what about you?
Yeah, for me, I'll speak more to the context in which technology exists. I'm really not a technology guy. I'm just looking around for the tools that work. And the thing that sort of shifted my attention to my place in the silver tsunami and the demographic wave of aging and the expected challenge of dementia in our population was the personal story of Robin Williams' wife presenting the information that we all wondered, was there an explanation? Was it just depression? No, it wasn't. It was a very severe neurodegenerative disorder called Lewy body dementia that we recognized poorly, and the suffering that he experienced in the last part of his life is the kind of suffering I want a healthcare system that knows how to respond to. And as we age as a population, I want to build soul into the healthcare system so that there's room for caring for each and every one of us, no matter what we face. And the technology is just what's in my environment to do that work.
Wow. Neil, you're going to finish us off. What was your big story?
Well, that was the Texas Medicaid story that I had. So that was it, yeah.
That's great. No, I thought that was great. And, well, I as always, I appreciate everybody tuning in here on MedHeads. For Dr. Michael Fratkin, for Neil Versel, for Stephanie Baum, and for myself, Chris Seper. Thank you very much. We'll see you again here next week. Take care, everybody.
Thank you so much.